Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 547 of our pharmacotherapy series, which majors in bipolar disorder. The first case reads, TJK, a 35-year-old man, is hospitalized and treated with lithium for a severe manic episode. He had a stable lithium level of 0.84 milliequivalent per liter for several weeks, but his last two levels were 0.65 and 0.61 milliequivalent per liter without any change in his drug therapy. TJK insists that he is taking the medication as prescribed. The nursing staff believes that he is adherent with his medication, but notes that he is spending more time off the unit and in the cafeteria. What factors could contribute to a decrease in TJK's lithium levels? Drug interactions are a common cause of changes in lithium levels, but there have been no changes in TJK's regimen. Changes in formulation or brand may sometimes have an impact on lithium levels. Nevertheless, lithium is relatively well absorbed and has a long elimination half-life, so this usually does not result in large changes in the 12-hour post-dose lithium level. Occasionally, patients switched from lithium citrate to solid dosage forms experience small changes in lithium levels. TJK should be questioned about his visits to the cafeteria because diet can have a major influence on lithium excretion. If TJK is consuming large amounts of caffeinated beverages or salty snacks, a reduction in lithium levels could occur. Increases in dietary sodium intake and the ingestion of methylxanthanes, e.g., caffeine, and theophylline, can increase lithium clearance. Finally, acute mania can increase lithium clearance. If TJK was showing signs of a relapse, his decrease in lithium levels might be attributable to his return to a manic state. The next case reads, PAJ, a 36-year-old woman, has been maintained successfully on lithium therapy for 5 years for bipolar disorder. She asks whether she should stay on lithium because she plans to become pregnant in the near future. While there is considerable disagreement about the importance of lithium as a teratogen, it has been associated with a variety of congenital malformations, including the rare cardiac malformation, Epstein anomaly. Lithium was originally thought to increase the risk of Epstein anomaly 400 times. However, the risk is more likely 20 to 40 times higher than in the general population. The current estimated overall risk for congenital malformations related to lithium treatment is approximately 4% to 12%, compared with 2% to 4% in controls. Because malformations are most likely to occur in the first trimester of pregnancy, it is advisable for patients to avoid lithium, when possible, during this high-risk period. In addition to cardiac malformations, infants exposed to lithium have been reported to have hypertonia, nephrogenic diabetes insipidus, and thyroid abnormalities. Lithium administration during pregnancy increases the risk of premature delivery by a factor of 2 to 3. Unfortunately, the relative safety of other psychotropic agents commonly used in bipolar disease is either not ideal or unknown. Valproic acid and carbamazepine are categorized as U.S. Food and Drug Administration, FDA, Category D during pregnancy. The general consensus is that these medications are genuine teratogens and should be avoided. Among 1,558 exposures, lamotrigine, FDA Category C, had 35 major congenital malformations among first trimester monotherapy exposures, that is 2.2%, with a 95% confidence interval of 1.6% to 3.1%. Typical and most atypical antipsychotics are classified as pregnancy Category C, suggesting that adverse morphologic outcomes are less common with these treatments than with mood stabilizers. Clozapine and lurasidone are pregnancy Category B. In a comparison of atypical antipsychotics of placental passage, olanzapine was associated with the highest exposure, that is 72% ratio of umbilical cord to maternal plasma concentrations, followed by haloperidol, that is 65%, risperidone, that is 49%, and quetiapine, that is 24%. Olanzapine was also associated with the highest rates of low birth weight and neonatal intensive care unit admissions. PAJ and her physician should discuss her individual risks related to lithium treatment. In addition to the risks of teratogenicity, they must consider the harm that could result from the possible recurrence of episodes of mania or depression and the risks inherent in discontinuing lithium or switching to another anti-manic agent. Also, PAJ should be actively involved in the decision-making process. If PAJ and her physician decide that she is to remain on lithium, her serum levels must be monitored closely during pregnancy and her dosage adjusted accordingly. Lithium clearance increases during the third trimester by 30% to 50%, resulting in a reduction in lithium levels and a need for dosage adjustment. Approximately 16 to 18 weeks after conception, screening tests, high-resolution ultrasound, and fetal echocardiography can be used to determine whether cardiac defects have developed. If possible, PAJ's physician should consider decreasing the lithium dose before delivery to minimize lithium levels in the newborn and to offset the reduction in lithium excretion that occurs after delivery. If PAJ and her physician decide that she is to discontinue lithium, they must be prepared to deal with the risks of lithium discontinuation. Several cases of presumed rebound mania have occurred after abrupt cessation of lithium therapy. If lithium is to be discontinued in PAJ, it should be gradually reduced over at least 4 weeks. The next case reads, PAJ did not use lithium throughout her pregnancy. After delivery, PAJ and her physician decide to restart lithium. How soon can lithium be reinitiated in PAJ? Lithium can be restarted as soon as PAJ's urine output is established and she is fully hydrated. However, This decision also may be affected by whether or not PAJ chooses to breastfeed her child, because lithium passes into breast milk and is present in concentrations up to 72% of that found in the maternal blood. Risks to the newborn include hypothyroidism, cyanosis, hypertonia, lethargy, and cardiac dysrhythmias. Hydration status must be closely monitored because lithium toxicity may develop during infantile illnesses. Thus, PAJ and her physician must discuss the advantages of breastfeeding versus the risks of exposing the newborn to lithium or withholding lithium during the postpartum period. PAJ should be informed that approximately 40% to 70% of women with BD experience affective episodes after delivery. If PAJ chooses to breastfeed while taking lithium, she should consider using infant formula when the child becomes ill, because febrile illness, vomiting, and diarrhea can increase the risk of lithium toxicity. She also should be instructed to contact her pediatrician if the infant experiences diarrhea, vomiting, hypertonia, poor sucking, muscle twitches, restlessness, or other unexplained changes in behavior. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 548.